I think we're going to get started because it's after 7 o'clock and we have less than an hour to go. So I am going to introduce myself and then the rest of my esteemed faculty on this great Tuesday evening here in New York City. My name is Robert Lookstein. I am the president-elect of the PERT Consortium, which is hosting this event. The event is Catheters for Clots. It is a multidisciplinary faculty conversation webinar about the state of the science, the state of the evidence or lack thereof for endovascular therapy for the treatment of acute pulmonary embolism. I am so honored and so grateful to have such an esteemed faculty tonight. I'm going to do my best to introduce them. The faculty that we've assembled represents, in my humble opinion, the endovascular disciplines that are participating in endovascular PE therapy. I'm not even going to name people's specialty or discipline because I want the conversation to be specialty neutral. But in no particular order, we have Efthymios Avgerinos from University of Pittsburgh. We have Wissam Jaber from Emory. We have Ken Rosenfield from Mass General Hospital. We have Suhail Dohad from Cedars-Sinai in Los Angeles. Also from Los Angeles, we have John Moriarty. We have Keith Sterling from Innova Health in the Virginia, Washington area. We have Vivian Bishay from Mount Sinai Hospital in New York. And again, I'm Rob Lookstein. I work in New York as well. So, again, the topic tonight is endovascular therapy for pulmonary embolism. We were all casually talking before we got started tonight about sort of how we're practicing in 2020 and how it's a little different than perhaps when we formed our own PERT teams and when we came up with a concept of endovascular therapy for PE. And so I'm just going to sort of jump into this. Wissam, if I could ask you a question. Right now, it's September 2020. How many endovascular PE cases is your team getting asked to do a month? How many are you choosing to do a month? And if I could ask you to break it down of how many you're doing catheter-directed lysis as a bucket versus thromboaspiration or embolectomy as a bucket, what are you doing now?
Thank you, Rob. Thanks a lot for the invitation. It's a great team here that I'm honored to be with. To get to the question, we've been doing this for several years, and things have morphed a little bit. Well, initially we had only the option, if we're going to take the patient to the cath lab, to do catheter-directed lysis. Now we have more options with catheter thrombectomy and some support, patient support also, not just with catheter, but putting them on things like ECMO and other type of supports. Now with time, we started doing maybe more and more catheter embolectomy just because the patients maybe improve quicker on the table, but all options are still open. I looked at the numbers lately, and we've done maybe in the last 5 years about 90 catheter-based embolectomies and maybe 150 catheter-directed lysis. But this is distributed among 2 to 3 hospitals, and we get referral patients. So this is by far not the majority of the pulmonary embolism patients. So when I looked at our numbers, if you look at the submassive patients and the intermediate risk patients, I would say probably 20 to 30% are treated with catheter therapy that gets sent to us. These patients frequently do well when you leave them alone. So if you find a little increase in RV to LV ratio and otherwise they look fine, most of them do well. We tend to take, because you asked this question, we tend to take to the lab people who look sicker, who have significant desaturation, blood pressure is borderline, they're tachycardic, somebody I'm really worried about where the risk is elevated. The data is a little limited there of who to take. So to answer this question, really, this is totally opinion and based on personal experience and limited data. So what I'm saying is just my practice. It's not really an endorsement of what has to be done. Maybe in the last year, we've done maybe 60 or 70% catheter embolectomy rather than catheter lytics, just to get the patients better quickly on the table, to avoid maybe ICU stays, but any of the treatments are still open on the table at my institution.
Vivian, could you start with that, what Wissam said, and say, what's happening in New York? Have you seen the same changes in the last year to 2 years, and what has that change been?
Yeah, absolutely. Thanks, Rob. I think we see similar trends. Overall, we're probably covering 4 hospitals, large hospitals that have PERT engagement, and then there's several hospitals that we will siphon towards the larger hospitals in the advent where they may need additional advanced therapies. But for the submassive group, and then the massives are also discussed on the PERT, but those are often receiving, I would say, more often systemic lytic therapy primarily. And then in the submassive group, the same thing, sort of the high-risk intermediates are the ones where we're more concerned about decompensation, or they have additional signs where they may be in that subset that will decompensate. Those patients will be referred for some form of advanced therapy, and how that breaks down, I think, has shifted as well. Typically, maybe 3 years ago, we were doing almost all catheter-directed lysis in those patients, not necessarily ultrasound added to that, but just standard lysis catheters. And now there's much more of a shift. At one point we were doing some small bore, and now that we have the addition of large bore, I think, there's that tendency to see the large clot that can be removed, and then the rapid improvement if the patients are selected correctly on the table. And so we're probably shifting more towards that. So I'd say it's a similar breakdown where there's, of all the patients that get additional therapy, it's maybe 60% are embolectomy, suction embolectomy versus catheter-directed lysis. But within institutions, it's variable at each hospital as well, based on the referrers and the comfort level they have with new devices. So there's variation across the system as well.
Thank you. Makis, what's happening in Pittsburgh? Is your group getting more referrals, and are you seeing the similar shifts also? Is there a different demographic that you're being asked to consult on?
Yes, in Pittsburgh we cover the Western Pennsylvania area, and with increasing awareness, we're seeing more and more patients now referred to our hospitals from the community. And while we are seeing more patients, I have to add to the previous speakers that the rate of patients that we are now intervening is actually less. We are still retaining a fair amount of procedures per year, but we are intervening in fewer patients compared to what we have been intervening early on. Early on, whoever showed up, we would probably intervene on. What experience, though, improving and realizing that there is like a fair amount of interventions that you can see, we are better selecting our patients now. And for the submassive PE group, we are definitely better selecting the patients in the really, really high risk ones. Not only the ones who have RV dysfunction and positive biomarkers, but high heart rate, soft blood pressure, or high oxygen requirements. And yes, there is a shift towards catheter thrombectomies, aspiration thrombectomy compared to thrombolysis. And I would still have, though, a 50-50 case share in between both techniques.
Keith, let me ask you a very pointed question. You're an accomplished trialist. You've been involved with many of the seminal trials regarding endovascular therapy. We're all talking about this emergence of thromboaspiration. You're covering a very busy health system. How do you decide when to use one technology versus the other? And I think all of us on this call are dealing with this every single day. You look at somebody and you're like, what do I use? So do you want to take a stab at that question?
Sure, $1 million question. So, I mean, I think that differences now I agree with the other speakers. First of all, I think we are actually treating fewer patients now because I think we know a lot more about, the pathophysiology of the disease when many of us weren't even treating PE, certainly some people 5-10 years ago, and now we're treating these patients. So there's a lot we've learned on that. I'll speak for our practice. We cover a bunch of hospitals in the area, but I can't really speak for the whole DC metro area because there's a lot of hospitals and people are doing things differently elsewhere. I think that, we do have some data, as you pointed out. We were part of some of the really important trials. I think we're still a lysis first practice because I think we do have supportive data that at least helps us for what we're doing. A big difference now, as also pointed out, is that we have some of the thromboaspiration devices that we didn't have a couple of years ago. And so for us, we would use suction or mechanical thrombectomy when patients were not candidates for lysis, yet they still had criteria that warranted treatment. And again, the intermediate high risk patient population or stable massive, if you will. And now we have devices that actually have decreased the percentage because we were really lysis heavy before because of lack of adequate devices. We've shifted a little more towards a percentage of thromboaspiration, but I'd still say we're a lysis first because, again, relying on the data, because I still think there's a lot we don't have in terms of information from data. And I'm hoping, because as you pointed out, we have a lot of industry people paying attention to this discussion, that we're going to have support for some of the important trials that are going to help us to answer questions, which device, which patient, and potentially when. I mean, we may all, because I think there is a large shift towards treating just intermediate high-risk patients and staying away from those intermediate low-risk patients that some of us were treating 5-10 years ago. But we may find out that there's quality of life data that actually says maybe we should be treating those patients, not just that they're going to live and not require other escalation of therapy, but that they're a patient population that may benefit. But I still think there's a lot of information we don't have yet from trials, Rob. Thanks,
Keith. Suhail, John, LA, usually ahead of the curve here. Suhail, I'll start with you. How are you trying to decide? Again, you get called the next hour. Somebody has a troponin leak. They're short of breath. They're on a non-rebreather mask. What are you going to do now, and what's going to make your decision about which technology you're going to use? We're all struggling with this, and I think it's important that we all share this sort of question mark with the global audience that we have tonight.
So yeah, thank you for having me, first of all, and greetings from the smoke of LA. But in any case, I think we have a very small, compact PERT team. So I think we make decisions fairly rapidly when we actually get called for a consult such as that. Most importantly, I think we don't rush to judgment. Sometimes we'll watch them for an hour or 2 or 3 to see if what their trend lines are between their heart rate, their high oxygenation level, the amount of clot they have on their CT angio, how much residual clot they have in their legs, what's their PA pressure, and then decide whether we're going to intervene or not. And that's the first thing. The second, I think, is, as like Vivian mentioned and Wissam mentioned, I think we're definitely doing less thrombolysis than we were doing 2 years ago. At that time, we were probably doing 80% thrombolysis, and most of our thrombolysis was ultrasound directed. But at this time, we're using more and more thrombectomy. We started off mostly with small bore thrombectomy. We use large bore thrombectomy only in patients who are extremely high risk or are on the kind of the cusp of very high risk intermediate to a full-fledged high risk PE, and decide whether we're going to use large bore or small bore. I think that's kind of how we've decided, and I think we're doing certainly less interventions today than we were doing a year ago. But I think we're doing a fair amount. We do about 40 to 50 cases a year between thrombolysis and thrombectomy.
John, I'm going to ask you, how many cases are you doing a month? What's your breakdown? And again, with all the different options that we have, which is pretty radically different than a year ago, how is your team making a decision about how to protocol the case, how to set it up?
Yeah, thanks, Rob, and thanks to everyone on the panel. This has been really great so far. Per month, our PERT team, we get about 20 activations, so about 4 to 5 per week, give or take. And we, leaving aside filters, will do an intervention, a pulmonary directed intervention on about one of those. So about 20% per week. So, 4 to 5 per month, multiply that up per year. And we've seen the same trends as everybody has, where we are definitely treating less people who are, in the kind of submassive low risk population, and probably seen some creep in the high bleeding risk population, where previously people who, for whatever the million different reasons that, people are high bleeding risk when they come to any institution, but particularly to an academic place like UCLA, where it seems like everyone's had 2 transplants or a brain resection last week or something, then we're doing more thromboaspiration. I will say that our approach, and this is difficult from an Irish guy, is to try and be humble, to remember that you have to be respectful of the fact that the data isn't that great, that being dogmatic about one device versus the other, or this one technique versus, something else that you may have seen somewhere or heard about, that can lead you down a path that maybe doesn't always lead to success. And so I think, we have ways of working, but we try and be flexible to change that based on what data we have and where that's recently changed.
Thanks, John. Kenny, I need you to answer this question. You were one of the first people to come up with the idea of a PERT. Everyone's saying that our practice is different than it was 5 years ago when you had the light bulb go off in your head. How are we going to evolve as a field? Are we going to define the patients that are the so-called high-risk submassives that we really need to treat, or are we just going to start treating more and more massives? What are you seeing in Boston, and where do you think we're going to evolve? I know that's a big question, but I'm really looking to you for wisdom here.
I don't know if I can share any better wisdom than the panelists that I'm sharing the podium with. But I think that, first of all, I think the team-based approach has really facilitated a better decision for each patient. And I would say that for our part, it's taken what was a wide divergence of practice and narrowed that divergence so we don't have great variation or not as much variation in practice. And I think that's a huge advantage, Rob, of the PERT or the pulmonary embolism response team approach, where you're making rapid decisions as a team. So you're, in a bygone era, it would be one person would be called and said, "Oh, I'm going to take him to the lab." And I think that was sort of the implication that people were making here on the panel, is that it used to be, we did more stuff before. I have to say that at our PERT, the discussion amongst the team members really actually contains us a little, keeps us from doing things that are maybe unnecessary. And that concept that I think it was Suhail, I'm not sure who mentioned it, that you wait and watch and see, make an initial assessment and say, I think the patient's doing okay. We don't like the way they are, but maybe with anticoagulation alone, they will get better. And actually, a majority of the time they do get better, and they transition to a better phase, and they go from high risk intermediate to a better grade. But if then they at 6 hours, or somebody said 1 hour, we often tend to wait 6, 7, 8 hours before making that reassessment, or continually reassessing, but then making decisions in a more sort of educated way with more people inputting. I don't know if that's really answered your question, but I do think that that's the transition that I've seen, is a better decision making, even in the absence of an evidence base. And actually, that's what the PERT concept was all about, is that we, in the absence of an evidence base, how do you make these decisions about whether to give any therapy at all beyond anticoagulation, whether to do half dose or full dose systemic lysis versus catheter-directed lysis with any number of catheters? And do you use a standard catheter or an ultrasound-directed, or now one of the newer devices that are being studied? or do you do thromboaspiration, or do you take them to the operating room? And there's no evidence base to support one thing over another in many of these patients. So the best way to come to a decision is by consensus with a group of experts. So that's the direction we're going. But I really hope the direction, Rob, and I'll finish this up now, is to say, I really hope the direction is that to collect more data using, for example, the PERT registry, which you are now spearheading, and you're at the apex of that thing, that we get more and more data to actually help us answer these questions.
I was going to plug that. Thank you for plugging it for me. And I'm going to go round robin to the faculty about that in a couple of minutes. But a couple of interesting questions have come in, and I sort of want to go around the faculty to ask. Vivian, you've probably done more thromboaspirations than anybody, in New York at this point, certainly that I know closely. How much of a learning curve is there? And, how many cases did it take you to get comfortable and saying that, I know this is a case I can do safely, or I really feel comfortable using this technology where it's going to benefit the patient? I think that's a very important technical issue to share with the broader population here on the call.
Yeah, great. I mean, there's definitely a learning curve there. It's a much larger catheter, obviously. So just safely getting it up into the pulmonary artery, that's the first step, and feeling comfortable with that you're not doing anything dangerous as you're transitioning through the heart is definitely takes at least a handful of cases. But I think eventually it becomes a question of who should you be taking, in particular for that modality of treatment, because I think it matters where the clot is, what type of clot you think it is it centrally located, is it saddle, and also what the morphology of the heart is will also make it possibly more challenging. So if the patient has, baseline pulmonary hypertension from prior PE and their pulmonary artery is really large, those cases can be more challenging at the outset, I think, than after you've gotten, say a dozen under your belt. So there's definitely a learning curve there, and there's risk associated with it. So you don't really want to do that on, someone you're not choosing specifically is a good candidate for that you feel you can do it safely.
Thank you. Wissam, you're involved with a big cath lab, lots of hospitals that you're covering. I think I was on a bunch of panels last year when the technologies were just starting to get FDA approved. And many of us were saying, is this going to be a technology that only one person is going to do? Does the whole cath lab team or the whole IR team or vascular surgery team, does everyone get trained on how to do this? Do you do it at one hospital, at 4 hospitals? How are you figuring out how to incorporate a clearly disruptive technology into your practice at the physician level?
That's, Rob, such an important question. I think it's all depending on the operator themselves. I mean, it's rather than facility that's able to do things, because all these patients present, and sometimes they're very acute and massive, to one of these hospitals, and transfer is not always that easy. So it depends if you have the individuals in that hospital that are comfortable treating pulmonary embolism in a specific way. One of the catheters, obviously, that take the most training, although you may need maybe 5 or 10 cases to be very comfortable with it, would be the large bore aspiration, like Vivian was saying. In my institution, and we cover 3 different big hospitals, we're 3 people that do it. We almost always can find somebody to go to one of the hospitals to do it when needed on the patients. And if I tried maybe to have some of my other colleagues to do it, some are not interested, some are busy with other things. So it's really a matter of people who are willing to take that on and treat these high-risk patients sometimes, and sick patients, and taken out of your time. We have 3. Frankly, if you ask me which modality to use, I frankly, with my experience, and with my couple of my colleagues' experience, we favor using the large bore aspiration because of the immediate improvement and our kind of safety records with it. When do we use the catheter lysis would be when I have partners who are not comfortable doing it. This is when we go ahead with that therapy, when one of us is not available to do it. I've also had a few cases where we're unable to aspirate enough clots with the large bore catheter or with the small bore catheter too, and we left the catheter lysis overnight in the patient. But that's pretty much summarizes the practice. We try on almost every case to put them in some sort of a trial, whether it's in the registry, for sure the PERT registry, but also in some sort, whether it's an industry registry or whether it's a trial that's PI initiated. But I really urge everybody, and maybe this is something you're going to bring up later. I'm not going to steal that thunder right now.
John, can you comment at UCLA? Are you doing any? Wissam sort of mentioned perhaps combination therapy. Are you doing cases where you're doing thromboaspiration to debulk it, and then perhaps doing catheter-directed lysis also? There's a lot of questions from the audience. We thought about that, I think, in New York for a little bit, and then we've moved away from it. What are you guys doing in LA?
I would say that we are primarily picking one modality and then sticking with it, whether that's lysis or aspiration. But there are people who are either salvage, where you really need to debulk the thrombus, so you aspirate some and then put them on lysis to further get benefit. Or people who don't respond to thrombolysis, whether it's, there's some degree of chronicity or for all the many different reasons. And so I think that, there are people on the edges who get both, but the vast majority, we pick something, try and make that work, and then move on after that.
Keith, you're the head of a medical board at a very, very large healthcare delivery system just south of me. I've been sort of tiptoeing around this issue, but this concept of thromboaspiration is so disruptive. Have you thought about introducing either credentialing to the medical board for this technology, or have you thought about restricting it in any way? It's a different procedure than just putting in catheters, obviously. So I'm just curious, in your administrative role, looking out for patient safety and trying to deal with doctors, how are you thinking about it?
Well, I mean, fortunately right now, a lot for PE, a lot of the devices for treatment of PE have largely been handled by, at least in our system, from interventional radiology for those devices. And, we work in groups. And so for people who are not as experienced or just starting out, we make sure that we have other physicians doing the cases with them. So we're not leaving anybody on an island, because I think, as it was pointed out before, putting in lysis catheters is technically a little bit easier. Not that it's without its risks, right? Because any operator who is not as experienced navigating through the right heart can spend a fair amount of time manipulating to get those catheters where you want them, and then have its own set of problems. But I think that right now there is no separate, quote, credentialing of these large bore devices. I think that a lot of them are pretty slick. They're large, but they are, I think, within experienced operators in catheter work. I think it's within their practice to be able to do that. But I think that those of us who are, heads of groups and things like that, make sure that we have whoever's handling it has adequate help. Okay. I mean, there's more than one person doing one of those cases, certainly if need be. I mean, we do the same thing with other technologies like EVAR as well. I mean, so I think it's important to recognize you don't want somebody handling these devices, whether it's on this panel or elsewhere, that doesn't have experience. Navigating the right heart, I think, is the most important thing.
Makis, let me shift gears a little bit. We're all talking about our choices on how to start a case, how to send it up. Let me shift a little bit. How do you end a case? All right. And I think many of us struggle with this. I've done a case where I've done catheter-directed lysis, and the pressures don't budge at all. I've done thromboaspiration where I'm pulling out clot and more clot, and then I can't pull anything else out. I'm doing an angiogram. There's still clot there. I don't know how much to keep going. How do you feel confident knowing that the case is over? And I know that's a loaded question, but I'm hoping you can take a stab at it.
No, we are treating patients. We are not treating images. So starting or amount of clot. So starting with catheter thrombolysis, I mean, early on, probably people would take back to the operating room and again shoot more arteriograms. But now we'll just initiate thrombolysis, and based on the clinical signs, the hemodynamic variables, as we are seeing the heart rate coming down or oxygen requirements coming down, we are typically happy to pull the catheters out at 6 to 8 hours. That's typically enough. You don't want to overdo it and get bleeding complications. There is a sweet spot, typically around 8 hours, when you see some clinical hemodynamic improvement to pull the catheters out at the bedside. Now, the answer is more difficult for suction thrombectomy. How much clot is enough? And we know there is no actual correlation of the thrombus amount to the clinical improvement. But if we see a pressure reduction on the table of roughly 20 to 30%, that's typically enough to say, I can stop.
Got it. Thank you. Suhail, in your lab, when you're doing a thromboaspiration case or you're treating somebody who's sort of teetering on the edge of massive, do you have a different setup than if you're just doing catheter-directed lysis? Are you thinking about ECMO? Have you done a case where you've had somebody on ECMO and then you're doing catheter-based therapy? I'm well aware that you guys have a very, very expansive ECMO program. So I'm just curious what your support system is and how do you think about that when you're called to see the patient?
So that's a great question, Rob. So when most intermediate high-risk PE patients that I do, I don't use anesthesia, and I have a very simple setup for the cases. But if I feel they have a very large thrombus burden, they're severely hypoxemic, I will use one of my cardiac anesthesiologists in the lab. We are fortunate that we have about 5 cardiac anesthesiologists that are always in the cath lab. We always have perfusionists in the cath lab. So for us to put a patient on ECMO is very, very simple. Having said that, we try not to intubate these patients. We try and manage them, even if they're hypoxemic, we'll try and get them on the table and try and do a very rapid aspiration thrombectomy, even a large bore aspiration thrombectomy for these patients who are teetering on the edge. Will work very, very fast. And I guarantee you that if you can get the catheter up and debulk a little bit, their hemodynamics and their oxygenation improves dramatically and rapidly while you're on the table. So I think that if you can get this done in a expeditious way, it's rare that you'll have to actually intubate them or put them on ECMO. Most of the ECMO patients that we see come in full arrest or are in extremis in the ER, and we'll put them on ECMO. And if they have a PE, we'll bring them to the lab and then debulk them.
Thank you. All right, I'm going to shift gears again. Kenny was plugging the database before, so I want to sort of introduce our global audience a little bit to the database, and then I'm going to ask everybody on the panel a couple of questions about it. So we've been running the database for about 1.5 years. We've got about 36 sites across the country. That's increasing almost every quarter, and we have over 3,700 patients already enrolled in the database. Well over 1,800 of them are intermediate risk. About 500 or so are high risk. The rest are low risk, or somebody didn't choose to classify it. And we're actually doing a data collection right now. So I want to start with you, John, just because you're at the top of my screen. We're sitting on 3,700 patients worth of data. What question would you like to see answered out of that experience across North America that would help you treat patients better?
Yeah, I think there's one question that comes to mind. We already get some really important data with the benchmarks that gets sent out to the participating sites. And so, for example, I know how UCLA now compares to the national average when it goes to 30-day readmissions. That's super important. But the question that I think that I would really like to find an answer to over time is, are we appropriately risk stratifying these people? Are the people that we are saying are intermediate, high, low risk, etc., are they having worse outcomes on a very predictable basis compared to people in other cohorts? Because that seems to be the most difficult thing, is picking out the people who are going to have a major adverse cardiac event and the people who are going to be perfectly fine with a minimum of conservative care.
So you want to see outcomes?
Yeah, I think so, yeah.
Okay, Keith, do you want to add anything to that? What's the burning question you want to see out of this 3,700 person database?
Well, I think outcomes are key. I would like to see, because at the end of the day, who's paying for this, right? So we're going to have some quality of life outcomes that are actually meaningful to understand which patients we're treating. I think that we all feel great about treating these very sick patients. And as you've heard pretty much every panelist say, they're treating sicker, higher, intermediate, high-risk patients. But I do think that we really need that answer on, for the people who are not catheter people, who are saying maybe they're just anticoagulation is the way to go with these patients. Are we actually making a difference in the patients we're treating? And what's happening to the patients who we're not treating with catheter-directed therapy? Because at the end of the day, that's going to help us drive what we're going to do. It's not just the lives we're saving short term, it's the lives that we're saving in terms of morbidity and other medical events long term.
Marcus?
We definitely need to compare the patients who get an intervention against those who do not get an intervention. And it's not only about mortality rates, because the majority of the patients we do eventually do not die. It's about quality of life. So looking a year or 2 years down the road, I would like to know, how do these patients do in terms of long-term PE sequelae, exercise intolerance, shortness of breath, etc. So this is what I'm looking for: major complications and long-term quality of life between groups.
So I just want to make sure I'm summarizing this correctly: acute adverse events, and then long-term quality of life outcomes. Okay, Vivian, same question.
I mean, I think those are the major ones that would probably be at the top of the list for all of us. And then some kind of comparative data between devices as well would be nice, which we don't have at all, really. So,
Wissam?
I think a lot of the studies looking at mortality in PE talk about mortality in general, and very few studies get in details about who's dying from PE, and that ties eventually to who gets benefit from interventional or aggressive PE treatment. So I'd like to understand who and why they're dying from PE and not from comorbidities, and try to kind of discern that. The other question in my mind that's always hard to find is what's happening to the massive PE patients. This is the population that does the worst, and we still don't have any good treatment for it. So how are we treating it? What's the outcome now? Has PERT affected that positively? How many are we putting on ECMO? So it really just a descriptive data of what's going on out there with this massive population.
Thank you. Suhail, what would you like to see out of the database?
Just to add to the litany of stuff, I think that the big advantage of these larger registries is to pick up some low frequency safety events. So I think that if there's one thing I would like to know is if we're using catheters and catheter directed thrombectomy, are we causing any harm to these patients? Is there a higher frequency of hemoptysis? Is there any other complication that we are creating that may not be a high frequency event, but it certainly may be a fairly morbid event?
Kenny, that's a great point, Suhail. Kenny, you and I have spoken about this, about as we're increasing the profile of the devices that are causing the tricuspid valve, are we damaging the tricuspid valve apparatus? And I'm curious what your thoughts about that are. Again, you've been involved with a lot of these feasibility studies. You're integrally involved with the database. And what do you think that we should all be looking at in terms of safety moving forward?
I think it's really going to be hard to define that tricuspid valve issue without really focusing on it, Rob. It's a great question, really good question that you have actually specifically brought up many times. I'd love to explore it. I don't even know how to look at that. But I do think that the database it's really hard to do comparative effectiveness with the database right now in its current state with the number of elements. When we get to 100,000, we might be able to do that better. But even then, it's not controlled, prospective, randomized trials. However, you have brought this up before, Rob, and that's that I think the database, somebody else said that, it gives us the landscape of what's happening. And also, I'd like to know what the database shows about the other adjunct treatments. For example, what do you do with clot in transit? What's happening with those patients? And they're infrequent enough, these things, that the way that people are treating clot in transit can only be looked at with a large database that's bringing, it's culling lots of information from a lot of different sites. And the same thing with other adjunct treatments like filters. What is the appropriate use of filters and so on. I'm hoping that we know there's a role, and what is everybody's utilization and what's happening? What's the landscape look like? And then what you've mentioned to the FDA with this is, and they're excited about this possibility, is ultimately to use the database as a platform or as a launching pad for doing clinical trials, whether it's IDE level or otherwise, to help inform us about the best treatments that everybody's sort of grappling for. So I'm hoping that it can be can serve in that role ultimately.
Thanks, Kenny. John, you've been very interested in the idea of clot in transit for many years now. Could you share with us and with the entire audience, since Kenny brought it up, how is your approach to this very challenging entity evolved over the last several years?
Yeah, I think it is challenging. I think it's challenging because we know that it's super common. We know that we're picking it up on more people because we're doing echoes now on everybody. But what we don't really know is where the presence, the size, the morphology, the mobility or immobility of all of these right heart lesions that we're picking up fits into their overall risk stratification. So we think that it makes them a higher risk, but does that make them high enough to warrant a immediate thrombectomy with one of the many devices we have now, or can we watch them and then do a thrombectomy if something else happens? So I think it's something that is super interesting. What's happened with us and our practice is that we've gone from a kind of a knee-jerk reaction, I think, from seeing the clot in the right heart to removing it, to now being a little bit more circumspect about maybe watching it for a while, seeing how it fits in with the global kind of risk stratification, and then going from there.
Thanks, John. I want to shift a little bit to try and talk about where do we as a collective move forward in the next 5 years or so. We've been talking about the database. That's certainly a launching point to try and identify certain demographics, perhaps look at outcomes. But we're all thinking about how do we answer these burning questions. And so Wissam, I want to start with you. Name one or two trials that you would like to see get off the ground in the next 5 years that would really, really make an impact on what we've been talking about for the last 45 minutes or so? Where do you think are the unmet questions?
Yeah, I think the answer is simple. I mean, the purest answer is I want to see catheter-directed therapy versus only conservative therapy, not against lytics, in patients in the intermediate to low risk. That's in a randomized trial. I mean, that's what we really need, a randomized trial there. I think there's enough patient there to be randomized, and there's enough uncertainty that we need that to happen. And the high-risk population, massive patients, that's a little trickier. It's hard to really do a randomized trial with the massive population, and this is where we need to do something. But maybe if we take the patients that are not as massive, the high-risk submassive, and we randomize these patients, so patients with borderline blood pressure, tachycardia, some signs that we can agree on that we know increase significantly the risk. And these are the patients that we randomize to catheter therapy versus systemic lytics. This is what I think the focus should be. The massive population is another population where just observational trials could be performed. Some interventional trials could be performed because this is a population that's really underserved in terms of treatment with very high mortality. So I think these are the three pressing questions that I would choose for trials.
Keith, I'm gonna throw the same question at you. You've been involved with several trials so far. Wissam would like to see a randomized trial. Could we still randomize people in 2021 moving forward? And if the answer is yes, I hope it's yes, but I'm curious to what you have to say. If the answer is yes, who should we randomize? Where
Right.
where are we gonna really move this space forward?
Right. Thanks. And I think that I am excited for such a trial to be out there, which would be looking at those intermediate, high-risk patients and have well-defined criteria of who those intermediate, high-risk patients are. Because although we're all catheter people on this call or on this meeting, there's a lot of people who are not. As a matter of fact, I would say the vast majority of the country is not. And I think there's a lot of people who feel anticoagulation is still the appropriate thing and not doing intervention. And so I'd like to see that. I'd like to see the ability to get investigators who will actually randomize these patients who are committed to such a trial. And I think it can be done. I think we'll need cooperation. I think just because you do a lot of procedures won't be, you're not the guy necessarily for that trial. The other thing is, and I think so that'll help, I think, the larger community of people taking care of PE. But as we've heard, there's a lot of people doing a lot of different things, whether it's CDT, with or without ultrasound, small bore versus large bore aspiration. I think there's potentially some trial data, or even from the registry. I'm not so sure about that one, but I think a well-designed trial to look at, well, how much proximal clot do we need to remove? And how much distal clot do we need to remove? And is there a difference? If you use a device and get all the proximal stuff out, how do those people do? And I think comparing on a large scale patients in that trial, I think it'll really help us, whether we need to then do, like you heard most of us, we pick a device and we go with it. And, whether it's lysis or aspiration, that's what you're going to do. And I think most of us feel good about that. But maybe that's not the right answer. And I think that that would be helpful information for, the catheter people who are on this call. So thanks.
Marcus, you guys actually did a randomized trial just in Pittsburgh, which was a huge benefit. And, I think it really helped the entire community. I know you guys talk about this all the time. What trial are you thinking about next? Or what trial would you like to see the global community engage in next?
Well, to start with, as everyone said, we are all looking forward to the PE tract trial for the submassive PE patients, whether we are really helping them against anticoagulation only. But I also like Keith's suggestion. Suction thrombectomy actually takes care of the main PA clot, while catheter thrombolysis is taking care of the distal bed clot. What is it that actually makes a difference? Is it taking away the main PA clot or taking care of the distal branches? And I think for the long-term results, like looking at quality of life and pulmonary hypertension, taking care of the more distal clot may actually be beneficial. Or having devices who can do both. And this is something that the new devices may look like. Taking care of with suction thrombectomy, the main PA clot, and at the same time, some lytics to take care of the distal bed clot. Something to look for in the future.
Vivian, again, I want to double back to this. Do you think that we're in a culture right now? We're all experts here. We're doing endovascular cases. I think we all said at least once a week. Do you think that we could randomize people? Do you think that the culture will allow us to really do that, or do you think we've already boxed ourselves in?
I would echo what the group says in terms of the massive patients. I think it's a bit challenging to envision an RCT comparing embolectomy versus lytic versus, suction thrombectomy. But I think it's perfectly reasonable in the submassive population, given the data or the dearth of data that we have right now to create an RCT and use something other than surrogate endpoints to evaluate these patients. So using actual mortality and decompensation, cardiovascular decompensation, rather than the trials that we have, which are single arm and look at surrogates. It's not really real evidence, to be quite honest. So I think it's completely ethical to do a trial, in my mind.
Thank you. Suhail, I want to pivot to high risk and ask you a very directed question. I think we're all struggling with how to deal with high risk patients in our practice. Some of us are very comfortable doing it, some of us aren't. Is there an opportunity to create a data set where we can prove that maybe endovascular therapy once and for all has a true role here? And how would we even start to think about that?
I think that, I think Wissam was talking about randomizing this high-risk patients. I think that we can do a better job of getting patient-level data and have a prospective registry. I think that's still possible. We do it for a lot of our structural heart patients. We can collect high-level data to get into the weeds of really what patients we are choosing in this high-risk category. Are they truly high risk? And how are we making the decision to then look at that group retrospectively and then design prospective trials? Because I don't even know if we understand how to design a prospective trial in this high-risk population. Are we going to randomize device to device or device to thrombolytics? Or I'm not even sure that we understand how to devise a trial like that.
John, do you want to take a stab at how we would study and advance the science of endovascular therapy for high risk?
With difficulty. I think it's going to be super tough, but as Suhail was saying, we're not the first people to take an endovascular space and create a good trial. From structural heart, TAVR, EVAR trials, people have done it, and it's above my pay grade to say how we do it, but you need to draw a line somewhere and say that, right, we're going to take the devices we have on day 0, and we're going to compare what we got. And then obviously there will be technologic and methodologic changes over the course of that trial, but it will add to what we have.
Do you think that we can randomize high-risk patients, or do you think it's going to have to be done as a sequential prospective registry?
I think we can randomize. I think we can randomize because there are more than just interventionalists who are involved with PE care.
Kenny, what should the next high-risk trial look like?
Oh God, ask me the easy questions, will you?
You're in cleanup, my friend. You're in cleanup.
Man.
Only the softballs for you.
Look, I think it's challenging to randomize patients when you have. How do you eliminate bias? How do you eliminate John? I agree with you. We can randomize. We have to randomize, but there's so many people that carry with them such biases about aspiration now. I see these big clots, and then there's people who have biases about treating with anticoagulation. Look, most of these patients really get better with just anticoagulations, and they bring these biases to the table, and we have to actually find equipoise and not let people fall off of the pathway of science, and that is challenging. Everybody knows that's challenging, but I think we have to do it. We got to accumulate evidence in this space.
Thanks. We're nearing the top of the hour. I really cannot thank my panel enough here. You guys have been absolutely amazing. You make my job so easy to get really, really thoughtful people together and have a candid conversation about this. I'd like everyone to just have a sort of closing comment. We've talked about so many things tonight, how our practices are changing, how we're struggling to make heads or tails of this, where the opportunities are for research and data moving forward. And so if there was something that you wanted the global community, physicians, industry to hear as a closing comment, please share with it now. I'm going to start with you, Keith. Closing remarks.
Right. I think that, continuing to spread the word about advanced treatment options for patients who have, pulmonary embolism is important in all of our communities, because I still think there's a lot of patients who are not having even the question of can you get treatment by, an appropriate endovascular physician. So I think that's one comment I'd like to make. I would like to continue to encourage our industry partners to help us with, honestly, device evolution, and also with helping us support these important trials that I think are going to help all of us in the long run. So that's my closing comments.
Marcus, closing comments.
It's an exciting new world. We really need to protect these interventions by producing more evidence and getting these in the appropriate hands.
Thank you. Vivian, closing comments.
I think it's a really exciting time for PE. I think we really need to figure out who the patients who would actually benefit from advanced therapies are, and go forward in that fashion.
Thanks. John, closing comments.
I echo everything that's said, and I just want to congratulate the PERT Consortium for getting the word out. This is what's needed to patients, to physicians, to people who are involved in the PE space, to everybody to work together. I think this is the way forward.
Suhail?
Yeah, I would echo what John and Keith just said. I think the most important thing that we can educate our peers is please form a dedicated PERT team and take care of these patients. They are orphan patients sometimes, and nobody wants to take care of them. So every institution requires a PERT team, and I encourage everyone to get together and do it.
Wissam?
We had fun this hour. Thanks a lot. We might have all appeared uncertain about what we're doing, but I truly believe that we're on the right path. We're doing the right thing by taking the patients that we're taking to the cath lab or the OR by doing these things. But I urge everybody to think, every time they're working on any patient, to think, what trial is this patient going to be put in? What registry am I going to have to put this patient in? Because we need every single bit of data generated by what we're doing to advance this science.
Thank you. Kenny, my friend, I'm turning to you. Wrap this thing up.
Join the consortium, engage in it, attend the meeting, the online meeting. It's really important. Join the registry, support Rob Lookstein in his effort to increase that registry, and all of us, frankly, in the community. Educate, because I think the biggest thing is, I mean, we're here as a group of people, and all the attendees who are numerous, by the way. It's awesome how many people are watching this, hundreds from all around the world. Actually, we really need to inform the medical community and the lay community about pulmonary embolism, because we're just scratching the surface. This is the group of people who are actually aware. The people who are unaware, there are many, many more, and people are dying a lot from this disease. I actually think it's bigger than stroke, believe it or not. I do believe that. It's just second to, it's third to heart attack, stroke, and just below stroke. But I think if we count all the true patients who have PE that aren't being recognized, it's actually more than stroke. So that's it. A couple of other comments. Yes, it's a moving target with all these great new therapies that there's a lot of excitement about, a lot of investment in that. Yeah, but we need to actually look at them carefully and make sure that we do apply them safely in the right patient population. We didn't even talk about the use of ECMO. We mentioned a little bit, but there are some people who believe that ECMO should be used much more often. And then finally, the importance of defining endpoints better, quality of life, long-term follow-up. We need to make sure that in our PERTs that we set up, Suhail, I love what you said about setting up a PERT and a multidisciplinary team. You need to follow those patients up long-term so we can really look at their quality of life. That's it.
Thanks, Kenny. So just for everybody on the call, thank you all for logging in tonight. Even though we were all so civilized and so respectful for each other, just to share it, many of us have never even met each other. And this was not rehearsed. I didn't give out any questions to anybody on this call. So for those of you that are curious about whether this was rehearsed, whether or not we had planned this whole thing out, this was 100% spurious, off the cuff. Nobody knew what I was going to ask and where this conversation was going to go. So this is honestly how all of us as humbly content experts feel about this. We absolutely know we're affecting patients' lives, but we need to prove who is going to derive the most benefit, how we can get the word out, how we can refine the technique, how we can develop more science, more comparative effectiveness data, more randomized trials. This is critical. And again, to echo everyone's comments here, we're in this for the long haul. We want to save people's lives. We want to improve their quality of life. Thank you all for attending tonight. And my last glorious plug for the annual meeting, please, please, please log into the 6th annual PERT Consortium annual meeting on October 23rd to October 24th, 2020. It's an online symposium. I'm one of the course directors, so I'm plugging my own meeting, but it's going to be a lot more of this. So if you're interested in endovascular therapies, please log in and you'll get even more of this kind of content, including technical tips, patient selection, outcomes, etc. And there will be a very large data presentation about the database. So more to come on that. Thank you very much, everybody. Have a good night. Thank you to my faculty. Have a good evening.
Thank you.
Thank you.
Appreciate it.
Thank you all. Thank you.
Night.